if I had a patient with completely normal spirometry, but was having symptoms relieved by a short-acting bronchodilator,
Asthma,
they
definitely.
got asthma.
Yeah.
Yeah.
So because I guess the way you look at that, they could have a normal FEV if they're not actually having an asthma attack. It's
Correct.
and
Yeah,
that's how you.
if they're doing well in the office.
And if something was off, that's how you would differentiate between asthma and the COPD. Is if you gave them um, SABA and they recovered versus it not doing anything.
Right.
Okay.
Yeah, that would have a lot to do with it. And typically, even though the book tends to kind of focus that COPD is reversible, where asthma is actually much more reversible when you give them a dilator.
Okay.
But I'm not going to ask you that specific question because I think the book interprets that in a somewhat difficult to understand means. So what they're trying to say is asthma is inflammation and bronchoconstriction. And the inflammatory portion often does not respond, but the bronchoconstriction side, that's a little higher level than you need to understand now. It's going to be a lot more, what's your FEV? Does it appear fixed? And symptoms and history. If you've got a 30-year-old non-smoker, exposure with symptoms, you're probably going to be more in the asthma range. If I threw a bunch of information about like a restricted disease, then that would be in there. But I don't think I have any super high level questions
and
like that.
And then one of the other things I had highlight was the risk factors for eosinophils will be increased. That we might have a question on that as well.
Yes. So what sort of things would potentially cause eosinophilia?
And that would be the asthma.
And
COPD.
I'm pushing.
Sorry.
No, not usually COPD. It would be asthma more and allergies.
Oh, that's right.
And certain types of esophagitis, parasitic infections, and then just weird stuff, just
I think I remember that from your lecture. I forget exactly what you said, but there was
worms and wheezes,
yes,
weird disease.
That's what it was. Okay.
Yeah. Okay. So I think you're good there.
Okay.
I want you to be careful just referring to the tables in the book. I think when we talked last time, you were showing me how you learn by kind of creating these tables. So make sure you spend a little time drawing up your own, and I think that'll fit your memory because I know you had some, very colorful, seemed like almost concept mapping of some of these disease processes. And I would encourage you to create your own tables based off the information. If you're time pressed, you don't have to be new and creative, just simply writing out the act of writing out what is in there, I think will help bring it, fix it in your memory. Because obviously it's closed book, you can't, refer to your tables while you're doing it. And just looking at the way you showed me you learn, I think spending some time just recreating those in your own writing is going to be helpful for you. But you seem to be, you got the right information under one. Broncho beta blockers would be cautioned because of their risk of increasing bronchospasm. Symptoms worse at night, concerning dyspnea, chest tightness, and remember cough. Cough can be a variant of asthma.
A symptom. Yeah, I think the biggest table that I focused on was one of the ones where it had intermittent, persistent, moderate, severe, and then underneath it, it had basically the treatment options for each of those.
Correct.
Like a low dose or like a high dose. And I've got little things in here like don't combine the SABAs together. Always use ICS with the short act or the LABAs.
Mm-hmm.
I think one of the questions, yeah. So the medications, I want to make sure that I have these correct. I'm trying to see which page. Here it is.
Yeah, because if you know that table, you want to be able to recognize what drug you would put in there. Now, I'm not going to put 80 milligrams of, fluticasone. I would put low dose fluticasone, okay? But you need to recognize fluticasone is an inhaled corticosteroid.
Okay, because I actually wrote out like fluticasone. I put its Flovent. It can be given in 2 divided doses, and the low is 88 to 264, medium 264 to 440, and then the high dose would be greater than 440. So I don't actually need to memorize these specific dosages, so to speak.
Correct. I do not have dosages anywhere based on feedback I got on the last exam. It's all going to be low dose, or medium dose, or high dose, I will say.
And the low
so
dose,
you do not
medium
need to spend
dose,
time memorizing.
and high dose.
High dose.
That is going to be
and I'll just,
kind of associated with the table, because the table says low dose ICS for persistent, mild persistent, or medium dose for moderate. So you're not going to actually have a number. We're just going to need to know that ICS means fluticasone, mometasone, I can't even pronounce it, but I thought